Imagine your body is functioning perfectly. Like it's healing, reacting, producing the exact physical results it's biologically supposed to, but your brain is just completely blind to it.
Right. It's this profound disconnect,
Right.
between physiological reality and conscious perception.
hmm
And it complicates everything we thought we knew about diagnosing sexual health.
Which is wild. Welcome to today's deep dive, everyone. We are so thrilled you're joining us. If you're the kind of curious learner who just wants to cut through the noise and get straight to those aha moments, well, we have a massive mission for you today.
We really do.
We are exploring this fascinating intersection of regenerative medicine and sexual health. Specifically, we're looking at the O-shot, that's platelet-rich plasma therapy. But we're focusing on a really nuanced medical challenge here. How do clinicians actually evaluate if the treatment is working?
Yeah, that's the real puzzle. How do they measure subjective improvements in how fast a woman becomes lubricated? What
Hmm.
the medical field calls lubrication latency during sexual arousal.
Right. And today we're pulling from a whole stack of sources. We've got clinical trial guidelines for platelet-rich plasma treatments. We're looking at the Female Sexual Function Index, the FSFI, and this incredibly compelling laboratory study out of the University of Texas at Austin.
Which is just a brilliant study. Because historically, medicine has had to rely entirely on what a patient feels, rather than what the body's actually doing in the moment.
Exactly. That tension is the core mystery for us today. The O-shot promises to restore natural physical responses, but to understand why measuring its success is so just incredibly complex, we really need to look at what the O-shot actually is,
So the O shot, or orgasm shot, it utilizes this regenerative therapy called platelet-rich plasma, or PRP.
which people might know from other fields.
Oh,
I'm
absolutely.
yeah.
Sports medicine, orthopedics, dermatology. The process is pretty straightforward. It begins with drawing a standard sample of the patient's own blood.
And then they spin it right
Yeah.
in a centrifuge.
Yes, exactly. They spin it down in a centrifuge to isolate and concentrate the platelets. Because platelets, they act as the body's first responders for tissue repair.
Because they're just densely packed with all those growth factors.
Right. They're essentially biological signaling mechanisms. So once this highly concentrated platelet-rich plasma is isolated, it is then injected back into the patient under local anesthesia.
But into very specific target tissues for this therapy.
Yes,
Yeah.
specifically the clitoral hood and the anterior vaginal wall.
Okay, let's unpack this because the clinical claims here are massive. The
Mhm.
sources show that when those concentrated growth factors hit that specific tissue, they stimulate this like cascade of regenerative effects.
It's a huge biological response.
Right. They trigger new collagen production, they promote nerve regeneration, and they significantly increase local blood flow.
Through neovascularization, yeah.
Right, neovascularization, which is literally the creation of new blood vessels.
Exactly. And the clinical expectation is that this cellular regeneration translates into functional, physical improvements for the patient.
Meaning they actually feel a difference.
Yes. The literature points to benefits like um, stronger orgasms, reduced pain during intercourse, and crucially, for our focus today, a marked increase in natural lubrication,
And this happens pretty fast, doesn't it?
usually within 2 to 4 weeks. As the tissue remodels, it can potentially eliminate the need for artificial lubricants altogether.
So it's essentially like using your body's own biological fertilizer to, I don't know, revive a dry garden.
That's a good way to look at it.
But wait, if this regeneration is happening internally, like on a microscopic cellular level, how do doctors definitively prove the garden is actually blooming faster or better?
If we connect this to the bigger picture, that is the primary hurdle in regenerative gynecology.
Because you can't just look at it and see new blood vessels.
Right. While the O-shot aims to improve the physical vascular health of the area, clinicians primarily evaluate its success through subjective patient-reported outcomes.
Which means they have to rely on questionnaires. If doctors can't easily, put a dipstick into the process or hook up a sensor in a normal office visit, they just have to ask the patient.
They do. And trying to put a hard number on an intimately personal experience like the timing of arousal is incredibly difficult.
So what are the gold standard tools they use to actually try and quantify this?
Well, clinicians use a few specific diagnostic tools to evaluate these treatments. You have the Patient Global Impression of Improvement, the PGII,
Okay.
and the Female Sexual Distress Scale, the FSDS.
Mm.
But the heavy hitter, the one that really matters in these clinical trials, is the Female Sexual Function Index, the FSFI.
The FSFI.
Oh, yeah.
Okay, I was looking at this in the sources, and it's a 19-item self-report tool, and the way it tries to evaluate latency and function is so specific.
It really is. It asks patients to score their experiences over the past 4 weeks across a bunch of domains.
Like desire, arousal, lubrication, orgasm, and pain. Right.
Exactly. And when we look specifically at lubrication, it asks two distinct types of questions to try and capture that timeline. First, it asks, how difficult was it to become lubricated?
Which is how they evaluate the onset, the latency, like how long did it take to get going?
Right, they're trying to measure the perceived delay. Then it asks, how often did you maintain your lubrication until completion?
Which measures the duration. How long did it last?
Exactly. The patient scores these answers, and a total score of 26.55 or lower across the whole index indicates clinical sexual dysfunction.
Okay, and to be fair to the O-shot, the systematic reviews in our sources show that it does actually work according to this metric.
The data is definitely promising.
Yeah, studies show that when clinicians do these PRP injections, and the standard seems to be about 2 to 6 milliliters injected once a month for 3 months, it results in statistically significant improvements in these FSFI scores.
Some trials even show the scores effectively doubling after the treatment.
But, and I have to push back here, human memory is just notoriously flawed, especially around highly emotional or intimate or vulnerable moments.
Oh, what a doubt.
Isn't relying entirely on someone trying to remember exactly how difficult it was to become lubricated 4 weeks ago just incredibly prone to bias? I mean, if I ask you what you had for breakfast 3 Tuesdays ago, you're guessing.
It is a massive vulnerability in the data. You are asking a patient to objectively recall a subjective feeling about an autonomous physical process. There are so many layers of interpretation happening there.
Right. And that exact question leads us to this massive revelation in the research. Because when scientists actually put these subjective questionnaires to the test against objective physical measurements, they found this shocking mind-body disconnect.
This is where the University of Texas at Austin study comes in, and it is brilliant. They ask what happens if we actually attempt to objectively measure the lubrication right in the moment.
Which sounds impossible without being super invasive.
Right, but they needed a way to measure it physically against the subjective feelings of arousal. So they took 64 premenopausal women. Half of them had clinical sexual arousal concerns.
Meaning they scored below that 26.55 cutoff on the FSFI.
Exactly. And the other half were healthy, functioning women without concerns. They brought them into a laboratory, and they were shown a 10-minute film.
Right, 4 minutes of a neutral film to get a baseline, and then 6 minutes of explicit sexual content.
And immediately after the film, they measured their physical lubrication and compared it to what the women reported feeling on a questionnaire.
And the results are just mind-blowing. The physical measurements showed no between-group differences in lubrication amounts.
None at all.
The women with sexual arousal concerns produced the exact same physical, biological response as the healthy women, down to the drop.
It's incredible. However, when looking at their subjective self-reporting, the women with arousal concerns reported experiencing significantly less lubrication.
Even though their bodies were doing the exact same thing.
Exactly. The correlation between their physical state and their subjective state was a very weak R equals 0.13.
Wow.
Yeah, compared to R equals 0.47 for the women without concerns.
So their bodies generated the fluid, but their conscious minds registered almost nothing.
What's fascinating here is how the researchers explain this. They introduced Barlow's model of sexual dysfunction.
Oh, right. David Barlow.
Yes. This model suggests that cognitive interference is the real culprit. It's a woman's assumption of how she should be performing or her distress over past difficulties.
So it causes this intense mental block.
Right. It causes her to subjectively underreport her own physical response. The anxiety literally diverts her attention away from her body's physical sensations.
So it's almost like a reverse placebo effect.
That's a great way to frame it.
Like your body is actually doing the thing, the medication or the treatment is working, but your brain is so anxious or hyper-focused on the worry that you don't even perceive it happening.
Exactly. Even if the O-shot physically works perfectly, if it restores the vascular health, a patient's cognitive expectations might prevent her from recognizing the improvement on that FSFI questionnaire.
Which is wild because then the clinical trial looks like a failure, even though the biology was fixed.
It completely disrupts how we view the efficacy of these treatments.
Okay, but this brings up a huge logistical question. If subjective reporting is this flawed, how did the UT Austin researchers actually measure the physical lubrication objectively? Because earlier you said standard exams can't just measure it easily.
This is where they got incredibly inventive. They repurposed a tool from a completely different medical field, ophthalmology.
Eye science,
Yes, eye science. They used Schirmer tear test strips.
which are usually used for dry eyes, right?
Right. They are FDA-approved little paper strips with a ruler printed on them, used to measure tear production, but they're highly sensitive to moisture from any mucous membrane.
So they repurposed them for the vagina.
They did. The patient inserts this 40-millimeter ruled strip exactly 5 millimeters deep.
At the 6 o'clock position, the sources said, which is the bottommost location of the vaginal opening.
Exactly. They hold it there for 60 seconds. And the moisture absorption is then measured by the color change on the paper in millimeters.
It's so simple but so precise, because old studies used to use, like, cotton swabs or tampons, which would just absorb everything and aggressively dry out the tissue.
Right, which ruins the environment if you want to take multiple measurements. The Schirmer strips provided a quantifiable number without destroying the baseline.
Okay, but here's the thing. While the Schirmer test proved that the physical lubrication amounts were the same between the groups at those discrete pre- and post-film checks, the researchers noticed a critical gap.
Yes, they did.
Uh-huh.
Because if the total volume of fluid is the same at the end of the 10 minutes, then what are the women actually complaining about when they say it's difficult to become lubricated?
Exactly. If the destination is the same, what's the problem?
The real difference between healthy function and dysfunction might not be the total amount of fluid, it's the trajectory.
The slope of the genital responding.
Yes. This raises an important question. If the total volume is the same, perhaps the difference lies in the time of onset of lubrication, the latency.
It's about the acceleration. Like, if two cars are trying to reach 60 miles an hour, one takes 3 seconds, a sports car, the other is a clunker that takes 10 painful minutes to reach 60.
Right.
The driver in the second car is going to report a terrible experience, even if they eventually reach the same speed.
That is a perfect analogy. The physical delay, the flattened slope of that biological response, is what causes the friction and the subjective distress.
So when patients are telling their doctors on that FSFI questionnaire that it is difficult to become lubricated, they aren't saying they are completely dry forever.
No, they're saying it takes too long.
And that waiting period causes the anxiety, which triggers Barlow's cognitive interference, which then makes them think it didn't happen at all. It's this vicious cycle.
It absolutely is. And because of this, the UT Austin study suggests that future treatments need to be designed specifically to alter the time of onset of lubrication.
They need to steepen the slope.
Yes, they need to fix the acceleration, which is exactly what treatments like the O-shot are attempting to do.
Right. By using platelet-rich plasma to regenerate local tissue and nerve pathways, they are trying to speed up that vascular response.
They want to make the tissue more sensitive and more reactive, so the time between mental arousal and physical lubrication is drastically shortened.
That makes so much sense. But until we start using objective tools to measure that exact reaction time, we're still stuck relying on patients to accurately report a timeline that their brains might be actively ignoring.
Which is why relying solely on subjective questionnaires is no longer enough.
Okay, let's wrap this up and summarize this deep dive for everyone listening, because we have covered some really paradigm-shifting ground today.
We definitely have.
So clinicians are using treatments like the O-shot PRP to try and regenerate tissue and improve lubrication and arousal times. However, evaluating if it actually works requires navigating this incredibly complex maze.
They currently rely heavily on subjective questionnaires like the FSSI. But, as we've learned, cognitive interference can severely mask a patient's true physical response.
Right, the brain just blocks it out. So moving forward, objective tools like those Schirmer tear test strips might help us finally measure the true slope, the latency of arousal.
And that actually leads to one final, really intriguing thought from the source material that I want to leave the listeners with.
Oh yeah, the limitation of the lab setting.
Yes. The UT Austin researchers noted that laboratory environment might actually inhibit the sexual responses of the sexually functional women.
I mean, obviously, nobody feels totally relaxed in a clinical lab room knowing researchers are standing right outside with clipboards.
Right. So they theorize that this clinical anxiety might have caused the healthy women's physical data to be artificially suppressed, causing their data to mimic that of the women with dysfunction.
Wow.
But here's the thing. The Schirmer tear strips are highly portable. They are just tiny paper strips.
She could just do it at home.
Exactly. So if future studies allow women to take these strips home and measure their physical responses in the privacy of their own bedrooms, could we completely rewrite the medical books on how female arousal, latency, and treatments like the O-shot actually work?
That is just a massive question to mull over. If we can capture objective, real-world data outside of a sterile lab environment, the gap between healthy function and dysfunction might look completely different.
It could change the entire diagnostic landscape.
Well, it seems like we're finally building the right kind of tools to map all of this accurately. It isn't just about what the patient feels anymore. It's about finding ways to truly see what the body is capable of doing. Thank you all for taking this dive with us today. Keep questioning, keep learning, and we'll catch you on the next one.